Hello friends, so today we are going to review the comprehensive pulmonary exam. The purpose for this video is to acquainted with the techniques of the various maneuvers in the pulmonary exam. Having said that, this will be a comprehensive pulmonary exam and you may not be able to do, or you should not do the whole exam in your 15 minutes of your OSCE. But this exam will be very helpful when you go in office setting or the inpatient setting, and whenever you have a patient with the pulmonary symptoms, that you can do the pulmonary exam. The first and foremost things you can see is the general appearance. And appearance can tell you a significant amount of distress if the patient is having any distress from the breathing issues. So what are the signs of various respiratory distress? If the patient is using any accessory muscles, that is a sign of a respiratory distress. So if they are using their neck muscles or their abdominal muscles, that is a sign of respiratory distress. One thing they can do that is called paradoxical breathing. So the normal breathing pattern is your abdominal thoracic. So your abdomen goes out when you're taking a deep breath and goes in when you're expiring. The reverse can happen, and that is called paradoxical breathing. Sometimes the patient cannot speak in full sentences if they're having significant respiratory distress, and that is also a sign of some trouble. So obviously our patient, Mr. Luke, does not have any paradoxical breathing. He does not have any, he has not been using any accessory muscles, and he does not have any trouble in speak. So he is not in respiratory distress. So moving from the general exam, we will look for a cyanosis, that is a bluish discoloration of your skin or the mucous membrane. There are two kinds of cyanosis, the peripheral cyanosis and the central cyanosis. So peripheral cyanosis you can see on the fingertips or the tip of the nose. So Mr. Luke does not have any cyanosis on his tip of the nose or the fingers. The central cyanosis you look in the mouth. Can you stick out your tongue for me? Okay. You can see on the palate, you can see under the tongue. So those are the signs for the peripheral central cyanosis, which he does not have. The other thing you look in a patient who has a chronic respiratory distress, particularly patients with COPD or emphysema, they have a pursed lip breathing. So they breathe out like this when they are exhaling. And that is a sign of chronic respiratory distress, and very important sign in a patient with a COPD. So Mr. Luke again does not have any pursed lip breathing, so no cyanosis, no pursed lip breathing. So Luke, I want you to lie down. Okay. Now the second thing, we are looking for any tracheal deviation. So trachea could be deviated on the same side or the opposite side for multiple reasons, and that can tell you something. So for the trachea that is situated in the center of the neck, you identify the trachea. Okay. Try to put your middle finger on the trachea and try to insert your ring finger and the index finger between trachea and the sternomastoid muscles. So if you are able to insert your finger between the trachea and the sternomastoid muscles, it means the trachea is centrally situated. Okay. So that is a trachea. Now if the tracheal deviation happens on the right side, you may not be able to place your finger between your sternomastoid and the trachea, which is not the case here. So that's the tracheal deviation. Now we are actually going to examine the lungs. Again, the four things you do is an inspection, palpation, percussion, and the auscultation. Okay, I want you to sit down. I'm going to untie your gown.
Mm-hmm.
Okay, so inspection, we are looking for any chest wall abnormality and the shape of the chest. Some people who has emphysema, they can have a barrel-shaped chest where your AP diameter is larger or similar to your transverse diameter. That's a barrel-shaped chest. That is not the case here. You see the precordium, you see any dilated veins or any chest wall abnormality. Now we are coming to the palpation, but before we move to palpation, just a little outline of the lung anatomy. So your front of the chest, usually you have the upper lobe of the lung. In the posterior of the chest, you have the lower lobe of the lung and only small portion of the upper lobe. On the right side, you have a middle lobe, which is situated on the lateral side. On the left side, you have a lingula, which is on the lateral side. So that's your upper, lower, and middle lobes. In the palpation, along with checking for any tenderness on the chest wall, tell me if it hurts, okay? Or any costochondral junction, we are doing two other things. One will be the tactile vocal fremitus, and the second thing will be the respiratory excursion. So what is a tactile vocal fremitus? It is a palpation of the vibration when the patient is speaking. You feel with the edge of your hand, and you feel it simultaneously on the both sides or one by one. So you compare the feeling on the one side with the feeling on the other side. Now we will discuss more when you get the higher feeling or higher tactile vocal fremitus in certain condition. You may have a decreased tactile vocal fremitus in certain condition. So Mr. Luke, I want you to speak 1, 2, 3 for me. You can go on this side. Say 1, 2, 3.
1, 2, 3.
Again.
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 1, 2, 3.
And the same thing in the front.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay. Can you just raise your hand? Okay.
1, 2, 3. 1, 2, 3.
Okay. Thank you. The next thing will be the respiratory excursion. So it is an effort of breathing and expansion of the chest wall. That is what we are trying to measure. Now, in certain condition, you have a less excursion or less expansion on that side of the chest wall, and we can notice that during the exam. So I want you to take a deep breath. So you, okay, take a deep breath in and out. Again. So as you see, the fingers are separated evenly on the both sides. So that is the respiratory excursion. Again. Okay. We can do that same thing on the posterior side. So holding the chest wall and asking the patient to take a deep breath again. So as you see, the fingers are separating evenly on the both sides. Okay. So that is the respiratory excursion. So in a patient who have a unilateral disease, they will have a decreased excursion, particularly pleural effusion or pneumothorax. It is not useful if you have a bilateral pathology. So if you have a bilateral pleural effusion, the movement will be the similar on the both sides, and that will not help. So that is a respiratory excursion. Now doing a percussion. So percussion, need to know you're using your two fingers to percuss on the patient's body. This is called plexor, which is the active finger that you are making a percussion, and this is called pleximeter, to which you are making a percussion. So you are trying to hit on the distal interphalangeal joint, and you are eliciting a note that you are comparing. Now the movement on the plexor hand should be through the wrist to elicit the maximum percussion. So I'm going to tap on your chest. Okay. So you ask the patient to make like this to open up the intercostal space in the back, and you do the percussion on the both sides one by one. And as you notice, the note on the both sides is similar. And the note you are getting in the lung field is a resonant note. You may get a dull note if you have a pneumonia or any consolidation. Now checking the percussion on the front and the lateral side. So this is your apex on the both lungs. Okay. Now in the front. Just like this. Okay, and now I'm doing on the lateral side. So that is a percussion on the lungs. Percussion of the lungs creates a different note on the lungs. The normal note is a resonant note. If you feel the dull note, that indicates underlying consolidation or pleural effusion or mass. If you have a resonant note which is hyperresonant, it may indicate that you have a pneumothorax or emphysema. So that is the percussion of the lungs. Now we are coming to the auscultation. So auscultation of the breath sounds. So you want to hear the whole breath, inspiration, a pause, and the expiration in all the lung fields. We'll start from the back and we'll examine the front later. So Mr. Luke, I want you to take a deep breath in and out through your mouth each time when you feel the stethoscope.
Okay.
So typically you want to listen the 3 spot in the back on the both side, on the lateral side, and the 2 spot in the front. While hearing a normal breath sound, you are also listening for any extra sounds that could be a wheezing or a crackle or the rhonchi, and that we will discuss more in our lecture. Along with the breath sound auscultation, you are also listening for a vocal resonance. So it's a auscultation of the sound that patient is making. It could be either a word or 99. So I'll ask you to say 99 every time when you feel the stethoscope.
99.
Again.
99.
Okay.
99. 99. 99. 99. 99. 99. 99. 99.
There is a variation of the vocal resonance is called egophony. So whenever you are listening over the normal lungs, when the patient is speaking E, you can listen E very distinctly. But in some situation, the E can be heard as an A, and that's called egophony. So I will demonstrate the egophony. If you can say E every time when you feel my stethoscope.
E. 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 E.
Thank you. So that was an egophony. In a normal person, you will hear very faint E, but in a patient who has a consolidation or the mass, you may hear A instead of E, and that is called egophony. lung exam is never complete without heart exam, and at least you need to auscultate the heart. So I'm going to hear your heart. Okay, thank you. In a patient with the chronic lung problem and right-sided heart failure, you may get the swelling of the leg. So it's also important to check for the edema on the leg. I'm going to press on your leg. There is no swelling. So that concludes our lung exam. Again, this is the comprehensive lung exam you may not be able to do in your OSCE setting, but this is the purpose of showing the techniques and the strategies. You can use that in your office setting or your inpatient when you're having a patient with the lung issues. So again, the general appearance for any respiratory distress, looking for any cyanosis or pulmonary breathing, making sure the trachea is centrally situated, inspecting the chest wall, palpating for any tenderness, tactile vocal fremitus, respiratory excursion and the percussion, auscultation for the breath sound and any extra sounds, vocal resonance and egophony, auscultating your heart, and looking for an edema. So that is a comprehensive pulmonary exam. Thank you.